Good afternoon. I'm Colleen Galambos. I'm a professor at the University of Missouri School of Social Work and Sinclair School of Nursing. And I'm here to talk to you about our innovations project with CMS. And I'd like to publicly thank CMS and our 16 facilities who decided to partner with us to help create this really exciting opportunity. Every day we learn something new about putting an intervention together and about some of the challenges that are out there in those facilities that we're working with. The initiative that we addressed is looking at how to reduce hospitalizations from skilled nursing facilities, vice versa, how to deal with that back and forth. We've also promised that this is going to be a scalable model and that we will save money through the use of this model. The story is that there were about 60 of us that sat around a table one day when the funding opportunity announcement came out and talked about the fact that Dr. Marilyn Rance from Sinclair School of Nursing has done a lot of really great work on quality improvement in nursing homes. And we sat around and we said, you know, Missouri may be positioned well for this kind of study because we've already done some preliminary work on it. And as we thought about it, as we talked about it, we saw ways that we could improve what we've already done in Missouri. So we put together a very complicated model, I think, but an interesting model. I'm not going to go into a lot of the particulars in terms of our logic model and the outcomes that we're going to be looking at because there's a lot of them. I'll explain briefly about the model and talk to you a little bit about some of our preliminary work. I am the care transitions lead for the project, so I want to spend a few minutes talking about that. Our model is one in which we have the patient and the family are in the center of the model, or the top of the triangle, if you will. And we work hand in hand with facility staff, and we provide an advanced practice registered nurse in each of the facilities that are partnering with us. And that advanced practice registered nurse is then supported by our MOQI team, which consists of a medical director, care transitions coach, which is a licensed master's prepared social worker, an Interact coach, who is a nurse who goes around to the facilities and teaches Interact tools. We are using Oshlander's model of Interact in terms of the quality improvement and processing instruments that he came up with. It's evidence-based, and prior to rolling out the intervention, he came out and he trained the preliminary staff on the use of Interact, and we continue to have periodic trainings due to turnover and some of the other challenges that you face when rolling out an intervention. In addition to the APRNs and the medical director, the care transitions coach, the Interact coach, we have a project supervisor, and then we have an information technology component of our model. What we would like to do, or what we are doing, demonstrating right now, is that the APRNs are there to really focus on early assessment, detection, and early intervention so we can treat right in the facility such occurrences as UTIs and other illnesses that we believe could be managed in the facility without being transferred to a hospital. So there's a focus on early recognition, assessment, and management. Another major focus of the project is to look at end-of-life decision-making and communication systems that are there to honor residents' and family wishes and to enhance psychosocial care. And this part of the project is the main focus of the care transitions team. In addition to that, we're looking at the transition process and communications in that transitions process. How does that add to errors in medication? How does that add to confusion in terms of that whole advanced care planning? Are those advanced directives being transferred and known about between care transitions? And we're really focusing on developing a care mail system, which has been rolled out in our 16 facilities, and we hope to have cooperation with hospitals related to that care mail system. Now, one of our challenges is when we thought about this technology component, we thought, oh, we can do a whole lot with this. Then we started to go into the facilities. And what did we find? We found that some of the facilities maybe had one computer. A lot of them had problems with Wi-Fi connections. We had our first rollout of APRNs who would have to go to one section of the building to be able to communicate with us. So we had to take care of that first before we could even think about rolling out systems of care. In my part of the project, where I'm looking at care transitions and I'm looking at advanced care planning, some of the things that we're finding is that while people have the best intentions about using care planning mechanisms like your care plan meetings to talk about advanced directives, it doesn't often happen. And it doesn't often happen that you include the family and the residents in those discussions. So what we're trying to do is normalize the process by really making a recommendation, and our APRNs are there to carry this out, make a recommendation that at each care plan meeting, we involve the families, we involve the residents, and we ask them about their wishes and their desires. And not to assume that what they have in the chart continues to be what they really want, because that changes over time. We're having some success with that. We're really excited about that. We're also looking at family involvement. What we're hearing from our facility is that the families are a challenge. The families sometimes get in the way of advanced care planning. What does that mean? What does that mean? Does it mean that they're vocal? Does it mean that they are advocating for their loved one? Or does it mean that they're getting in the way of what the resident really has indicated are their choices? I think is a combination of all of that. And it brings me to a point that I would like to make, and that is that we have to start to think about how to involve our families more. How to provide services, bring back family counseling, bring back family work. Spend some time with families so that you can get to what I call the backstory. We know what the front story is. The front story is right in front of us. But then you have all these emotions and these dynamics, and what it usually ends up being is that the nurse is on call and the social workers are getting very frustrated because this family member is there and is being persistent. These kinds of discussions cannot take place 20 minutes in a physician's office, cannot take place 10 minutes in the nurse's station. These discussions have to occur over a period of time. It may take an hour, it may take 3 hours, it may take weeks, it may take months. And it needs to be the kind of discussion that goes on for a long time, and you keep on checking and you keep on talking about it. If you provide the opportunity for people to make those kinds of opportunities for discussions, then you get to know what that real story is. What's the backstory? What happened to that family? What happened to that resident that is creating the emotion or the conflict that you are seeing? And that needs to be dealt with. If we can deal with that, if we can provide the resources to deal with that, we'd be much better off. Another point that I'd like to make, I know I'm out of time, is that I really believe that we need to look at an interdisciplinary intervention. I think the physician offers lots of information, the nurse offers lots of information, but we also need a patient advocate. That may be a social worker, it may be a chaplain, somebody who can help talk about that backstory, find out what that backstory is, talk about that backstory, talk about cultural implications, and really help advocate for that family and residents' interest. Very, very important. There's so much more that I can share, but my time is up. I encourage you to look at the poster that's over there, and I've also sent in written comments that I believe are going to be posted. So thank you very much for your time. It's been an honor to talk to you.